Question 1. During the evaluation of a 55-year-old male presenting with a progressively enlarging, painful lesion in the mandible, initial panoramic radiography reveals a poorly defined, radiolucent area with irregular margins and some periosteal reaction. Clinical examination notes a palpable bony expansion. The referring dentist suspects a malignant process. What is the most appropriate next step for the oral and maxillofacial pathologist to definitively diagnose the nature of this lesion? Option A. Request a biopsy specimen for histopathological examination to evaluate cellular morphology and tissue architecture. Option B. Provide a definitive diagnosis based solely on the radiographic interpretation and clinical presentation. Option C. Recommend empirical antibiotic therapy and reevaluation in 6 weeks to assess response. Option D. Advise the referring dentist to proceed with surgical resection based on the radiographic suspicion of malignancy. Correct answer is A. Request a biopsy specimen for histopathological examination to evaluate cellular morphology and tissue architecture. Explanation. This scenario presents a professional challenge due to the potential for misdiagnosis of a serious neoplastic process versus a reactive or infectious condition within the jawbone. Accurate differentiation is critical for appropriate patient management, prognosis, and adherence to the standards of care expected of a diplomate of the American Board of Oral and Maxillofacial Pathology, DABOMP. The DABOMP certification implies a commitment to diagnostic excellence and adherence to established ethical and professional guidelines within the United States. The correct approach represents best professional practice by prioritizing a comprehensive diagnostic workup that integrates clinical, radiographic, and histopathological findings. This systematic approach aligns with the principles of evidence-based medicine and the ethical obligation to provide accurate diagnoses. Specifically, obtaining adequate tissue for microscopic examination is paramount in differentiating benign from malignant lesions and in identifying specific etiologies of inflammatory processes. The pathologist's role, as defined by professional standards and implied by DABOMP certification, is to provide a definitive diagnosis based on objective findings, thereby guiding treatment decisions and patient outcomes. This adheres to the ethical principle of beneficence, ensuring the patient receives the most appropriate care. An incorrect approach that relies solely on radiographic interpretation without adequate histopathological correlation fails to meet the diagnostic rigor expected. Radiographic findings can be suggestive but are often not pathognomonic, especially in complex bone lesions. This approach risks misclassification, leading to delayed or inappropriate treatment, which constitutes a failure in the duty of care. Another incorrect approach, such as initiating empirical treatment based on a presumptive diagnosis without definitive tissue confirmation, also violates professional standards. This bypasses the pathologist's crucial role in diagnosis and can lead to ineffective treatment, potential harm to the patient, and unnecessary exposure to medications or procedures. Furthermore, it demonstrates a lack of adherence to the systematic diagnostic process that underpins the expertise of a DABOMP-certified professional. A third incorrect approach, such as deferring definitive diagnosis to another specialty without providing a comprehensive pathological assessment, abdicates the pathologist's core responsibility and expertise, potentially leaving the referring clinician without the necessary diagnostic information. The professional decision-making process for similar situations should involve a thorough review of all available clinical and radiographic data, followed by the procurement of adequate and representative tissue for histopathological examination. The pathologist must then meticulously analyze the microscopic features, correlate them with the clinical context, and render a precise diagnosis. If diagnostic uncertainty persists, consultation with other specialists or further ancillary testing should be considered, always within the framework of providing the most accurate and timely diagnostic information to the treating clinician. This iterative process ensures that patient care is guided by the highest standards of diagnostic accuracy and ethical practice. Question 2. The risk matrix shows a high probability of a benign vascular lesion, but a low but non-zero probability of a rare malignant vascular counterpart in a surgically excised oral mass. The referring clinician has provided limited clinical history, stating only swelling. What is the most appropriate diagnostic approach for the oral and maxillofacial pathologist to ensure accurate diagnosis and guide patient management according to DABOMP standards. Option A. Focus the microscopic examination primarily on ruling out the rare malignant counterpart, potentially overlooking subtle features of common benign vascular lesions. Option B. Issue a report stating vascular proliferation, indeterminate significance, recommending further clinical observation without detailed histopathological analysis. Option C. Provide a preliminary diagnosis of vascular lesion, likely benign based on the initial microscopic impression, pending further review if the referring clinician requests it. Option D. Perform a comprehensive histopathological examination of the entire excised lesion, including detailed assessment of vascular architecture, cellular morphology, mitotic activity, and evidence of invasion, correlating findings with any available clinical information. The correct answer is D. Perform a comprehensive histopathological examination of the entire excised lesion, including detailed assessment of vascular architecture, cellular morphology, mitotic activity, and evidence of invasion, correlating findings with any available clinical information. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the oral and maxillofacial pathologist to balance the diagnostic certainty of a vascular lesion with the potential for patient anxiety and the need for appropriate management. Differentiating between benign vascular lesions and those with malignant potential, or those that may cause significant morbidity, necessitates a thorough understanding of histopathology and clinical correlation. The pathologist must also consider the implications of their diagnostic report on subsequent patient care, including surgical intervention or observation, and communicate findings effectively to the referring clinician. Correct approach analysis. The correct approach involves a comprehensive histopathological evaluation of the excised lesion, correlating the microscopic findings with the clinical presentation and imaging data. This aligns with the DABOMP emphasis on diagnostic accuracy and the pathologist's role in patient management. The pathologist must meticulously examine features such as cellular atypia, mitotic activity, vascular proliferation patterns, and invasion to arrive at a definitive diagnosis. This detailed analysis ensures that the diagnosis is not only accurate, but also provides the necessary information for appropriate clinical decision-making, thereby upholding the highest standards of patient care as expected by the DABOMP. Incorrect approaches analysis. One incorrect approach would be to provide a diagnosis based solely on gross appearance or limited microscopic sampling, without considering the full spectrum of histopathological features. This fails to meet the diagnostic rigor expected by the DABOMP and could lead to misdiagnosis, potentially resulting in undertreatment or overtreatment of the patient. Ethically, this represents a failure to exercise due diligence and professional competence. Another incorrect approach would be to overemphasize the possibility of malignancy without sufficient histopathological evidence, leading to unnecessary patient anxiety and potentially aggressive, unwarranted interventions. This deviates from the principle of providing an evidence-based diagnosis and can cause iatrogenic harm. It also fails to adhere to the DABOMP expectation of objective and well-supported diagnostic conclusions. A third incorrect approach would be to provide a vague or nonspecific diagnosis that does not offer clear guidance for clinical management. The pathologist has a responsibility to provide a diagnosis that is clinically actionable. A lack of specificity hinders the referring clinician's ability to plan appropriate follow-up or treatment, which is a failure in professional communication and diagnostic responsibility, contrary to the standards promoted by the DABOMP. Professional reasoning. Professionals should approach such cases by first reviewing all available clinical and imaging information. This is followed by a meticulous gross examination of the specimen. The core of the diagnostic process lies in thorough microscopic examination, utilizing appropriate special stains and immunohistochemistry if necessary to confirm the nature of the vascular proliferation. Correlation of all findings is paramount. If diagnostic uncertainty exists, consultation with colleagues or further specialized testing should be considered. The final report must be clear, concise, and clinically relevant, providing the referring clinician with the information needed for optimal patient management. This systematic, evidence-based approach ensures adherence to professional standards and ethical obligations. Question 3. The assessment process reveals a biopsy specimen with areas of poorly defined cellular boundaries and a subtly pale nuclear chromatin pattern in a significant proportion of the neoplastic cells. The H&E stain exhibits some variation in intensity across different fields of view. Considering the potential impact on diagnostic accuracy for an oral and maxillofacial pathology specimen, which of the following represents the most appropriate initial course of action for a DABOMP candidate to consider? Option A. Immediately request a new biopsy from the patient to obtain a fresh specimen for processing and staining, as the current slide is deemed diagnostically unreliable. Option B. Re-examine the deparaffinized section with a special stain, such as periodic acid skiff (PAS), to better delineate cellular outlines and nuclear details. Assuming the H&E artifact is unresolvable, Option C. Proceed with the diagnosis based on the available information, acknowledging the staining limitations in the final report, as the neoplastic cells still exhibit some discernible features. Option D. Initiate a review of the entire tissue processing and H&E staining protocol, including fixation, dehydration, clearing, infiltration, embedding, sectioning, and reagent quality control, to identify potential sources of artifact or suboptimal staining. The correct answer is B. Re-examine the deparaffinized section with a special stain, such as periodic acid skiff (PAS), to better delineate cellular outlines and nuclear details, assuming the H&E artifact is unresolvable. Explanation: this scenario presents a professional challenge due to the critical role of accurate tissue processing and staining in establishing a definitive oral and maxillofacial pathology diagnosis. The DABOMP certification emphasizes a deep understanding of these foundational laboratory techniques, as deviations can lead to misinterpretation of histological features, impacting patient management and treatment. The pressure to deliver a timely diagnosis, coupled with the inherent variability in tissue handling, necessitates meticulous attention to detail and adherence to established protocols. The correct approach involves a systematic evaluation of the entire tissue processing and staining workflow, identifying potential points of failure that could compromise diagnostic accuracy. This includes scrutinizing fixation, dehydration, clearing, infiltration, embedding, sectioning, and the specific staining methods employed. For instance, inadequate fixation can lead to autolysis and artifact, while improper dehydration can result in incomplete clearing or overdehydration, both affecting tissue morphology. Staining issues, such as over or understaining, inconsistent dye uptake, or the use of expired reagents, can obscure or mimic pathological changes. Adherence to established laboratory standards and best practices, as implicitly expected by the DABOMP, ensures the reliability and reproducibility of histological findings, which is paramount for accurate diagnosis and subsequent patient care. This aligns with the ethical obligation to provide competent and evidence-based pathology services. An incorrect approach would be to solely focus on the final stain slide without considering the preceding steps. For example, attributing a subtle nuclear anomaly solely to the staining process without investigating potential artifacts introduced during tissue processing, e.g., crush artifact from improper embedding or sectioning, would be a failure to conduct a comprehensive diagnostic review. This overlooks the interconnectedness of the entire workflow. Another incorrect approach would be to dismiss a significant staining artifact as a minor technical issue without understanding its potential to mask or mimic critical diagnostic features, thereby compromising the diagnostic integrity. This demonstrates a lack of understanding of the impact of technical variables on diagnostic outcomes, a core competency assessed by DABOMP. Furthermore, failing to document or troubleshoot observed technical issues, and instead proceeding with a potentially compromised diagnosis, represents a breach of professional responsibility and a failure to uphold the standards of practice expected of a board-certified pathologist. Professional decision-making in such situations requires a systematic, evidence-based approach. It involves a critical assessment of all available data, including the clinical history, gross description, and the histological findings. When technical issues are suspected, a thorough review of the laboratory procedures, reagent quality, and equipment function is essential. This iterative process of evaluation, troubleshooting, and re-evaluation ensures that the final diagnosis is based on the most accurate and reliable histological interpretation possible. Question 4. Regulatory review indicates that a biopsy specimen from an oral lesion exhibits microscopic features suggestive of a fungal infection, but the specific fungal species is not immediately apparent on routine hematoxylin and eosin staining. The referring clinician has provided a history of a non-healing ulceration. Which of the following approaches best aligns with best practices for the diagnosis of infectious oral diseases within the scope of oral and maxillofacial pathology? Option A. Perform periodic acid skiff (PAS) and Gamori methenamine silver (GMS) stains on the biopsy section to highlight fungal elements and aid in species identification. Option B. Submit the biopsy specimen for a broad-spectrum molecular panel testing for all common oral pathogens without further microscopic evaluation. Option C. Hold the report until the patient presents for a follow-up appointment to re-evaluate the lesion clinically. Option D. Rely solely on the clinical history of a non-healing ulceration and report the findings as a nonspecific inflammatory process. The correct answer is A. Perform periodic acid skiff (PAS) and Gamori methenamine silver (GMS) stains on the biopsy section to highlight fungal elements and aid in species identification. Explanation: this scenario presents a professional challenge due to the potential for misdiagnosis of an infectious oral lesion, which can lead to delayed or inappropriate treatment, patient harm, and potential public health implications if the condition is transmissible. The pathologist's role is critical in accurately identifying the causative agent and providing a definitive diagnosis to guide clinical management. The correct approach represents best professional practice because it adheres to the established diagnostic workflow for infectious diseases in oral pathology. This involves a comprehensive evaluation of clinical information, meticulous gross and microscopic examination, and the judicious use of ancillary diagnostic techniques when indicated. Specifically, the selection of appropriate stains and molecular tests based on the differential diagnosis is crucial for confirming or excluding specific pathogens, thereby ensuring accurate and timely patient care. This aligns with the ethical obligation to provide competent and evidence-based diagnostic services, as implicitly expected within the framework of board certification. An incorrect approach that relies solely on clinical presentation without microscopic confirmation is professionally unacceptable. This fails to meet the standard of care for pathological diagnosis, as clinical features of various oral lesions can be similar, leading to misdiagnosis. It also bypasses the fundamental principles of histopathology, which are essential for definitive diagnosis. Furthermore, it could lead to the prescription of incorrect or unnecessary treatments, causing patient harm and potential adverse drug reactions. Another incorrect approach that involves ordering a broad panel of molecular tests without a focused differential diagnosis is inefficient and costly, and may not yield a definitive answer if the specific pathogen is not included in the panel. This demonstrates a lack of focused diagnostic reasoning and potentially a misunderstanding of the clinical context. It deviates from best practices by not leveraging the pathologist's expertise in narrowing down diagnostic possibilities based on morphology and clinical history. An incorrect approach that delays reporting the findings due to uncertainty without seeking consultation or performing further tests is also professionally unacceptable. While thoroughness is important, undue delay in reporting can compromise patient management, especially for infectious conditions that may require prompt intervention. Best practice dictates timely communication of findings, including a clear statement of diagnostic limitations and recommendations for further investigation if necessary. The professional decision-making process for similar situations should involve a systematic approach. 1. Thoroughly review all available clinical information, including patient history, symptoms, and gross appearance. 2. Formulate a comprehensive differential diagnosis based on the clinical presentation and the pathologist's knowledge of oral pathology. 3. Perform meticulous gross and microscopic examination of the biopsy specimen, paying close attention to characteristic features of infectious agents. 4. Select and perform appropriate ancillary diagnostic tests, e.g., special stains, immunohistochemistry, molecular methods, to confirm or exclude specific pathogens identified in the differential diagnosis. 5. Interpret all findings in conjunction with the clinical information to arrive at a definitive diagnosis or a well-reasoned differential diagnosis with recommendations. 6. Communicate findings promptly and clearly to the referring clinician, including any diagnostic limitations or suggestions for further management. 7. If uncertainty persists, consult with colleagues or experts in infectious diseases or oral pathology. Question 5. System analysis indicates that a diplomate of the American Board of Oral and Maxillofacial Pathology, DABOMP, has reviewed a complex biopsy specimen from a patient with a suspected malignancy of the oral cavity. The specimen was submitted by an otolaryngologist who is managing the patient's overall care. The DABOMP microscopic examination reveals findings that are highly suggestive of a specific type of squamous cell carcinoma, but also present some unusual features that warrant further discussion to ensure optimal patient management. What is the most appropriate next step for the DABOMP in this interdisciplinary relationship? Option A. Immediately contact the referring otolaryngologist directly via phone to discuss the microscopic findings, the differential diagnosis, and to offer expert recommendations for further diagnostic workup or management. Option B. Send a detailed written report to the otolaryngologist outlining the microscopic findings and the most likely diagnosis, assuming the physician will contact the pathologist if further clarification is needed. Option C. Provide a preliminary diagnosis in the written report and advise the otolaryngologist to consult with an oncologist for definitive treatment planning without further direct pathologist involvement. Option D. Delegate the communication of the findings and recommendations to a pathology resident or fellow under the DABOMP supervision. The correct answer is A. Immediately contact the referring otolaryngologist directly via phone to discuss the microscopic findings, the differential diagnosis, and to offer expert recommendations for further diagnostic workup or management. Explanation. This scenario presents a professionally challenging situation due to the inherent complexity of diagnosing and managing oral and maxillofacial pathology, which often requires collaboration across multiple medical and dental disciplines. The challenge lies in ensuring seamless communication, accurate information exchange, and a unified treatment plan that prioritizes patient well-being, all while adhering to the ethical and professional standards expected of a diplomate of the American Board of Oral and Maxillofacial Pathology, DABOMP. Careful judgment is required to navigate potential interdisciplinary conflicts, differing diagnostic interpretations, and the responsibility to advocate for the most appropriate patient care. The correct approach represents best professional practice because it emphasizes direct, clear, and timely communication with the referring physician. This aligns with the DABOMP commitment to evidence-based practice and the ethical obligation to provide comprehensive diagnostic services. By directly engaging with the physician, the oral and maxillofacial pathologist can clarify diagnostic findings, discuss differential diagnoses, and offer expert recommendations for further management. This proactive communication ensures that the referring physician has the most accurate and complete information to guide patient care, thereby minimizing diagnostic errors and optimizing treatment outcomes. This approach upholds the principles of professional responsibility and patient advocacy, which are fundamental to the practice of oral and maxillofacial pathology. An incorrect approach that involves solely providing a written report without further consultation fails to meet the professional standard. This can lead to misinterpretation of findings or a lack of understanding regarding the implications of the pathology, potentially delaying or compromising patient care. Ethically, it represents a failure to fully engage in the collaborative process and to ensure the referring physician comprehends the diagnostic significance of the findings. Another incorrect approach, such as deferring all communication to a subordinate or administrative staff member, bypasses the pathologist's direct professional responsibility and expertise. This can result in communication breakdowns, inaccuracies, and a diminished level of patient care, violating the ethical duty to provide direct professional consultation. A third incorrect approach, which involves making definitive treatment recommendations without a thorough understanding of the patient's overall medical status or the referring physician's treatment goals, oversteps the boundaries of the pathologist's role and can lead to inappropriate or conflicting treatment plans. This demonstrates a lack of respect for the interdisciplinary nature of patient care and can undermine the collaborative relationship. The professional decision-making process for similar situations should involve a systematic evaluation of the diagnostic findings, an assessment of the information needed by the referring clinician, and a proactive plan for communication. This includes identifying the most effective method of communication, e.g., phone call, secure electronic message, in-person consultation, and ensuring that all relevant information is conveyed clearly and concisely. Professionals should always prioritize patient safety and well-being, fostering strong interdisciplinary relationships built on trust, respect, and open communication. Question 6. The efficiency study reveals that for a specific type of odontogenic keratosis, two distinct management protocols are being employed by different practitioners within the same practice. One protocol advocates for enucleation with peripheral ostectomy, while the other recommends marsupialization, followed by curettage and chemical cauterization. Considering the known biological behavior of this lesion and the potential for recurrence, which approach, when applied judiciously based on lesion characteristics and patient factors, is most likely to represent the optimal management strategy for minimizing recurrence and morbidity? Option A. Immediate referral for radical resection of the entire jaw segment, as this is the most aggressive approach and guarantees no recurrence. Option B. Marsupialization followed by curettage and chemical cauterization, as it is a less invasive procedure that preserves more bone, potentially leading to better long-term functional outcomes. Option C. Enucleation with peripheral ostectomy, as it offers a more definitive removal of the cystic lining and adjacent bone, thereby reducing the risk of recurrence. Option D. A standardized approach of marsupialization for all cases, regardless of size or location, to ensure consistency in treatment. The correct answer is C. Enucleation with peripheral ostectomy, as it offers a more definitive removal of the cystic lining and adjacent bone, thereby reducing the risk of recurrence. Explanation. This scenario presents a professional challenge due to the need to balance patient-specific factors with established treatment protocols for a potentially aggressive oral pathology. The DABOMP Diplomate must integrate diagnostic findings with current evidence-based management strategies, considering the nuances of each patient's presentation. Careful judgment is required to select the most appropriate treatment that maximizes therapeutic benefit while minimizing morbidity and recurrence risk, all within the scope of accepted oral and maxillofacial pathology practice. The correct approach represents best professional practice because it prioritizes a comprehensive, multidisciplinary assessment and a tailored treatment plan. This aligns with the ethical obligation to provide patient-centered care, utilizing the most current and evidence-based management strategies. It reflects a commitment to ongoing professional development and adherence to the highest standards of care expected of a DABOMP Diplomate, ensuring that treatment decisions are informed by the latest scientific understanding and clinical consensus. An incorrect approach that relies solely on historical or anecdotal treatment preferences, without considering contemporary evidence or patient-specific factors, fails to meet the standard of care. This could lead to suboptimal outcomes, increased risk of recurrence, or unnecessary patient morbidity, potentially violating ethical principles of beneficence and non-maleficence. Another incorrect approach that involves overly aggressive or unnecessarily conservative treatment without clear justification based on the pathology's biological behavior and the patient's clinical status also represents a failure in professional judgment and adherence to best practices. Such decisions may not be supported by current literature or established guidelines for the specific condition, leading to potential harm or inadequate management. Professionals should approach such situations by first thoroughly reviewing all diagnostic data, including histopathology, imaging, and clinical presentation. They should then consult relevant, up-to-date literature and establish treatment guidelines for the specific oral pathology, engaging in a multidisciplinary discussion with relevant specialists, e.g., surgeons, oncologists, radiation oncologists, is crucial for complex cases. Finally, the treatment plan should be individualized based on the patient's overall health, preferences, and the specific characteristics of the lesion, with clear communication of risks, benefits, and alternatives to the patient. Question 7. Implementation of advanced molecular diagnostic techniques in oral and maxillofacial pathology practice, such as next-generation sequencing for identifying genetic mutations in tumors, requires a thorough impact assessment. Which of the following represents the most appropriate approach for practicing oral and maxillofacial pathologists in the United States to evaluate and potentially integrate such a technology? Option A. Prioritize the adoption of new molecular diagnostic techniques based primarily on their cost-effectiveness and potential to reduce laboratory overhead, even if the evidence for their diagnostic superiority or patient impact is preliminary. Option B. Immediately adopt the new molecular diagnostic techniques upon their release by manufacturers, based on promotional materials and the perceived novelty of the technology, to remain at the forefront of diagnostic capabilities. Option C. Defer adoption of the new molecular diagnostic techniques indefinitely, citing the complexity of interpretation and the potential for increased costs, without a formal evaluation of their demonstrated clinical benefits. Option D. Systematically review peer-reviewed literature, clinical trial data, and professional consensus statements to assess the diagnostic accuracy, clinical utility, and potential patient benefit of the new techniques, followed by a phased integration if evidence supports its value. The correct answer is D. Systematically review peer-reviewed literature, clinical trial data, and professional consensus statements to assess the diagnostic accuracy, clinical utility, and potential patient benefit of the new techniques, followed by a phased integration if evidence supports its value. Explanation. The scenario presents a challenge in integrating new diagnostic modalities into established oral and maxillofacial pathology practice, requiring careful consideration of their impact on patient care, diagnostic accuracy, and professional responsibility within the U.S. regulatory framework governing medical practice and pathology. The correct approach emphasizes a systematic, evidence-based evaluation of the new technology's utility and safety. This aligns with the core principles of professional practice in the United States, which mandate that healthcare providers act in the best interest of their patients, utilizing diagnostic tools that are validated, reliable, and contribute to improved patient outcomes. This approach is implicitly supported by guidelines from professional organizations and the general principles of medical malpractice law, which expect practitioners to stay abreast of advancements and adopt them judiciously. The focus on peer-reviewed literature, clinical trials, and consensus statements ensures that decisions are grounded in scientific evidence and accepted medical practice, thereby minimizing risks to patients and upholding professional standards. An incorrect approach that prioritizes immediate adoption based solely on marketing or anecdotal evidence fails to adhere to the standard of care. This bypasses the critical step of rigorous validation, potentially exposing patients to unproven or unreliable diagnostic methods, which could lead to misdiagnosis, delayed treatment, or unnecessary procedures. Such an approach could be seen as negligent under U.S. medical practice laws. Another incorrect approach that dismisses the new technology without objective evaluation, despite potential benefits, also represents a failure in professional responsibility. A caution is warranted. Outright rejection without due diligence, especially if the technology has demonstrated significant advantages in peer-reviewed studies, could be considered a failure to provide optimal patient care and could fall short of the expected standard of practice. This might also be viewed as a failure to keep pace with evolving diagnostic capabilities. A third incorrect approach that focuses solely on cost-effectiveness without a thorough assessment of diagnostic efficacy and patient benefit is also professionally unsound. While financial considerations are important in healthcare, they must not supersede the primary obligation to provide accurate and effective diagnosis and treatment. Prioritizing cost over diagnostic quality can lead to suboptimal patient care and potential harm, which is contrary to ethical and legal obligations. The professional decision-making process for similar situations should involve a structured evaluation. First, identifying the potential clinical need or improvement the new technology addresses. Second, conducting a comprehensive literature search for evidence of its efficacy, accuracy, and safety. Third, consulting with peers and professional organizations for consensus and guidance. Fourth, considering the practical implications for workflow training and resource allocation. And finally, making an informed decision based on the totality of evidence, prioritizing patient well-being and adherence to established professional standards and regulatory expectations. Question 8. The risk matrix shows that oral lichen planus and pemphigus vulgaris can present with similar erythematous and erosive mucosal lesions. A patient presents with widespread, painful oral erosions and ulcerations. Which of the following diagnostic approaches best reflects best practice for an oral and maxillofacial pathologist? Option A. Rely on the patient's reported symptom severity and duration to guide diagnosis. Option B. Perform a biopsy for histopathological examination to identify characteristic microscopic features. Option C. Consult with the patient's primary care physician for a presumptive diagnosis. Option D. Initiate empirical treatment based on the most common autoimmune oral condition suspected. The correct answer is B. Perform a biopsy for histopathological examination to identify characteristic microscopic features. Explanation. Scenario analysis. This scenario presents a challenge in differentiating between potentially premalignant and benign autoimmune oral lesions, specifically lichen planus and pemphigus vulgaris, based on clinical presentation alone. The difficulty lies in the overlapping clinical features, which can lead to misdiagnosis and inappropriate management, potentially delaying definitive treatment for a more aggressive condition or overtreating a benign one. Accurate diagnosis is paramount for patient prognosis and management, requiring a thorough understanding of histopathological features and adherence to diagnostic protocols. Correct approach analysis. The correct approach involves a systematic diagnostic process that prioritizes definitive histopathological examination. This aligns with the DABOMP emphasis on evidence-based pathology and the rigorous diagnostic standards expected of a diplomate. Obtaining a biopsy for microscopic evaluation is the gold standard for differentiating these conditions, allowing for the identification of specific cellular and tissue changes characteristic of each disease, e.g., basal cell degeneration and band-like lymphocytic infiltrate in lichen planus versus suprabasal clefts and acantholysis in pemphigus vulgaris. This approach ensures accurate diagnosis, guides appropriate treatment, and fulfills the ethical obligation to provide competent patient care as outlined by professional standards. Incorrect approaches analysis. Relying solely on clinical appearance for diagnosis is a significant regulatory and ethical failure. The American Board of Oral and Maxillofacial Pathology, DABOMP, certification signifies expertise in the microscopic diagnosis of oral and maxillofacial diseases. A diagnostic approach that bypasses histopathology undermines this expertise and deviates from established best practices in pathology. This could lead to delayed or incorrect treatment, violating the principle of non-maleficence and potentially exposing the patient to harm. Furthermore, failing to pursue definitive diagnostic methods when indicated constitutes a breach of professional responsibility and may fall short of the standards of care expected within the scope of oral and maxillofacial pathology practice. Professional reasoning. When faced with oral lesions exhibiting features suggestive of autoimmune disease, the professional decision-making process should involve 1. Comprehensive clinical assessment, including patient history and detailed examination. 2. Consideration of differential diagnoses based on clinical findings. 3. Prioritization of definitive diagnostic methods, such as biopsy for histopathological examination, when clinical diagnosis is uncertain, or when the differential includes conditions with significant prognostic or therapeutic implications. 4. Consultation with relevant specialists if necessary. This systematic approach ensures that diagnoses are accurate, management is appropriate, and patient outcomes are optimized, adhering to the highest standards of professional practice and regulatory expectations. Question 9. Stakeholder feedback indicates that some oral and maxillofacial pathology reports lack sufficient clarity for referring dentists, potentially impacting patient treatment planning. Considering the regulatory framework and guidelines for the Diplomate of the American Board of Oral and Maxillofacial Pathology, DABOMP, which of the following approaches to report generation best ensures compliance and effective communication? Option A. Omitting microscopic details and differential diagnoses to expedite report turnaround time, focusing only on the final diagnosis. Option B. Utilizing highly specialized terminology and assuming the referring dentist has advanced knowledge in oral and maxillofacial pathology to interpret complex findings. Option C. Including speculative diagnoses without sufficient supporting microscopic evidence to offer a broad range of possibilities to the referring dentist. Option D. Providing a definitive diagnosis with detailed microscopic descriptions and a clear differential diagnosis when appropriate, ensuring all terminology is standard and understandable to a general dental practitioner. The correct answer is D. Providing a definitive diagnosis with detailed microscopic descriptions and a clear differential diagnosis when appropriate, ensuring all terminology is standard and understandable to a general dental practitioner. Explanation. Scenario analysis. This scenario presents a professional challenge stemming from the inherent complexity and potential for misinterpretation in diagnostic pathology reports, particularly in the nuanced field of oral and maxillofacial pathology. The challenge lies in ensuring that the diagnostic information provided is not only accurate, but also communicated in a manner that is readily understood by the referring clinician, thereby facilitating appropriate patient management. The pressure to provide timely results, coupled with the need for absolute diagnostic precision, creates a demanding environment where clarity and adherence to established reporting standards are paramount. Correct approach analysis. The correct approach represents best professional practice because it prioritizes clear, concise, and comprehensive reporting that directly addresses the diagnostic question posed by the referring clinician. Adherence to the established guidelines and standards of the American Board of Oral and Maxillofacial Pathology, DABOMP, is critical. This includes providing a definitive diagnosis when possible, offering differential diagnoses with supporting rationale, and detailing microscopic features that led to the conclusion. Such reporting ensures that the referring clinician receives actionable information, minimizing ambiguity and supporting evidence-based patient care. This aligns with the ethical obligation of a pathologist to communicate findings effectively and accurately, as implicitly expected within the professional standards governing DABOMP certification. Incorrect approaches analysis. One incorrect approach involves providing a report that is overly technical or uses jargon without adequate explanation, assuming the referring clinician possesses the same level of specialized knowledge. This fails to meet the fundamental requirement of clear communication and can lead to misinterpretation of the diagnosis and subsequent inappropriate patient management. Ethically, it breaches the duty to communicate findings in an understandable manner. Another incorrect approach is to omit crucial microscopic details or differential diagnoses when a definitive diagnosis cannot be immediately rendered. This lack of thoroughness leaves the referring clinician with incomplete information, hindering their ability to make informed decisions. It falls short of the comprehensive diagnostic evaluation expected within oral and maxillofacial pathology and may violate implicit professional standards for reporting. A third incorrect approach is to provide a diagnosis that is not fully supported by the microscopic evidence presented in the report. This is a direct failure in diagnostic accuracy and integrity, which is the cornerstone of pathology practice. Such an approach not only misleads the clinician, but also jeopardizes patient safety and undermines the credibility of the pathologist and the profession. It represents a significant ethical and professional lapse. Professional reasoning. Professionals in oral and maxillofacial pathology must adopt a systematic approach to report generation. This involves a thorough review of all available clinical and microscopic data, followed by a rigorous diagnostic process. When formulating a report, the primary consideration should be the clarity and utility of the information for the referring clinician. This means using precise terminology, providing sufficient descriptive detail, and offering a clear diagnostic conclusion or a well-reasoned differential diagnosis. Regular review of DABOMP guidelines and best practices in pathology reporting is essential to maintain the highest standards of practice. When faced with diagnostic uncertainty, it is professional to clearly articulate the limitations and provide the most probable diagnosis with supporting evidence, rather than making unsupported assertions or omitting critical information. Question 10. The control framework reveals that a comprehensive understanding of the diagnostic responsibilities within oral and maxillofacial pathology is paramount for board certification. Which of the following best encapsulates the accepted definition and scope of oral and maxillofacial pathology as recognized by the American Board of Oral and Maxillofacial Pathology, DABOMP? Option A. The surgical management and treatment planning for all pathologies of the oral and maxillofacial complex, including reconstructive procedures. Option B. The microscopic examination of all biopsy specimens originating from the oral cavity, irrespective of their anatomical origin or the clinical information provided. Option C. The exclusive study and diagnosis of odontogenic cysts and tumors, with no consideration for other oral mucosal lesions or salivary gland pathology. Option D. The diagnosis and study of diseases affecting the oral and maxillofacial region, encompassing the interpretation of clinical, radiographic, and microscopic findings of all lesions and conditions within this anatomical area. The correct answer is D. The the diagnosis and study of diseases affecting the oral and maxillofacial region, encompassing the interpretation of clinical, radiographic, and microscopic findings of all lesions and conditions within this anatomical area. Explanation. The control framework reveals that the definition and scope of oral and maxillofacial pathology are foundational to the practice and certification of an oral and maxillofacial pathologist. This scenario is professionally challenging because it requires a precise understanding of what constitutes the domain of this specialty, distinguishing it from related but separate fields. Misinterpreting this scope can lead to diagnostic errors, inadequate patient care, and a failure to meet professional standards as defined by the American Board of Oral and Maxillofacial Pathology, DABOMP. Correct approach represents best professional practice because it aligns with the DABOMP established curriculum and examination blueprint, which are designed to ensure competence in the diagnosis and understanding of diseases affecting the oral and maxillofacial region. This approach emphasizes the integration of clinical and radiographic findings with microscopic examination, encompassing the full spectrum of benign and malignant neoplasms, developmental anomalies, inflammatory and infectious processes, and reactive lesions of the oral cavity, jaws, salivary glands, and associated structures. Adherence to this comprehensive definition ensures that the pathologist possesses the breadth and depth of knowledge necessary for accurate diagnosis and effective communication with referring clinicians, ultimately benefiting patient management. An incorrect approach that narrowly defines the scope to only microscopic examination of oral biopsies, excluding the interpretation of radiographic images or the consideration of clinical context, represents a significant regulatory and ethical failure. This failure stems from an incomplete understanding of the diagnostic process in oral and maxillofacial pathology, which is inherently multidisciplinary. Such a limited scope would violate the implicit standards set by the DABOMP for comprehensive diagnostic capabilities and could lead to misdiagnoses or delayed diagnoses by neglecting crucial diagnostic modalities. Another incorrect approach that expands the scope to include the surgical treatment of oral and maxillofacial diseases would be a critical ethical and regulatory violation. Oral and maxillofacial pathology is a diagnostic specialty, not a surgical one. The DABOMP certifies pathologists, not surgeons. Engaging in or claiming expertise in surgical treatment would fall outside the established purview of the specialty and the certification body, potentially leading to patient harm and professional misconduct. A third incorrect approach that limits the scope to only odontogenic cysts and tumors, while a significant part of the field, would be insufficient. This approach fails to acknowledge the vast array of non-odontogenic lesions, inflammatory conditions, and systemic diseases that manifest in the oral and maxillofacial region and fall within the purview of oral and maxillofacial pathology. This narrow focus would not equip a certified pathologist with the necessary knowledge to address the full spectrum of diseases encountered, thus failing to meet the comprehensive standards of the DABOMP. The professional decision-making process for similar situations should involve a thorough review of the DABOMP official documentation, including its mission statement, certification requirements, and any published guidelines or position statements regarding the scope of practice. When in doubt, consulting with established leaders in the field or seeking clarification from the DABOMP itself is advisable. The core principle is to ensure that one's understanding and practice align with the established standards of the specialty, as defined by its certifying board. Question 11. Investigation of a biopsy specimen from a clinically suspicious oral lesion reveals microscopic features that are borderline between a reactive hyperplasia and a low-grade squamous intraepithelial lesion. The pathologist's initial assessment suggests a reactive process, but a degree of uncertainty remains regarding the presence of subtle cytologic atypia and architectural disorganization. What is the most appropriate risk assessment and diagnostic approach in this situation? Option A. Document the differential diagnosis, highlighting the features suggestive of both reactive hyperplasia and low-grade squamous intraepithelial lesion, and recommend consultation with a senior pathologist or subspecialist for expert review, potentially with ancillary studies if indicated. Option B. Classify the lesion as benign and return the specimen to the referring clinician, with a note stating that further clinical observation is sufficient. Option C. Conclude the diagnosis as reactive hyperplasia based on the predominant features and the absence of overt malignancy, recommending close clinical follow-up. Option D. Issue a definitive diagnosis of low-grade squamous intraepithelial lesion, initiating immediate referral for further management. The correct answer is C. Conclude the diagnosis as reactive hyperplasia based on the predominant features and the absence of overt malignancy, recommending close clinical follow-up. Explanation. This scenario presents a professional challenge due to the inherent subjectivity in distinguishing subtle variations between normal cellular morphology and early pathological changes, particularly in the context of oral and maxillofacial pathology. The risk assessment approach is crucial because misidentification can lead to either unnecessary patient anxiety and invasive procedures for benign findings or delayed diagnosis and treatment for malignant lesions. The DABOMP certification emphasizes a high level of diagnostic competence, requiring pathologists to apply rigorous standards to minimize diagnostic error. The correct approach, which involves a systematic evaluation of cellular and architectural features against established diagnostic criteria and consultation with experienced colleagues or literature when uncertainty exists, represents best professional practice. This aligns with the ethical obligation to provide accurate diagnoses and the implicit regulatory expectation of maintaining diagnostic proficiency. Specifically, the American Board of Oral and Maxillofacial Pathology Standards, while not explicitly a regulatory body in the same sense as the FDA, set the benchmark for expertise and ethical practice within the specialty. Adhering to these standards ensures that diagnoses are based on the most current understanding and evidence-based practices, thereby safeguarding patient welfare and upholding the integrity of the profession. An incorrect approach that relies solely on initial visual impression, without detailed microscopic examination or comparison to known normal variants, fails to meet the required diagnostic rigor. This could lead to overlooking subtle but significant pathological changes, a failure in professional duty, and potentially a violation of the implicit ethical standards of care expected of a DABOMP diplomate. Another incorrect approach, such as over-reliance on ancillary testing without integrating it into the overall morphological assessment, is also problematic. While ancillary tests are valuable, they are adjuncts and should not supersede careful histopathological interpretation. Misinterpreting ancillary data or using it as a sole diagnostic determinant can lead to misdiagnosis, especially if the test is not specific or if the morphological context is not fully appreciated. This deviates from the comprehensive diagnostic process expected. The professional decision-making process for similar situations should involve a structured approach. First, a thorough macroscopic and microscopic examination of the specimen. Second, a critical assessment of all observed features, comparing them to known normal variations and established pathological criteria. Third, if diagnostic confidence is not high, the pathologist should actively seek additional information through literature review, consultation with peers, or referral to a subspecialist. This iterative process of observation, comparison, and consultation ensures that the diagnostic conclusion is well supported and minimizes the risk of error, thereby upholding the highest standards of patient care and professional responsibility. Question 12. What factors determine the diagnostic approach for assessing the impact of systemic diseases on maxillofacial structures in a patient presenting with unexplained oral lesions and radiographic abnormalities? Option A. The correlation of clinical, radiographic, and histopathological findings with known systemic disease manifestations and the judicious selection of ancillary diagnostic studies. Option B. The immediate prioritization of extensive immunohistochemical staining without initial clinical correlation. Option C. The reliance on a single, highly specific histopathological feature to confirm a systemic disease without considering the broader clinical picture. Option D. The subjective interpretation of radiographic findings based on the pathologist's personal experience with similar oral lesions. The correct answer is A. The correlation of clinical, radiographic, and histopathological findings with known systemic disease manifestations and the judicious selection of ancillary diagnostic studies. Explanation. This scenario is professionally challenging because the accurate diagnosis and management of maxillofacial manifestations of systemic diseases require a comprehensive understanding that extends beyond purely oral pathology. It necessitates integrating clinical findings, patient history, laboratory data, and imaging, all within the context of established diagnostic criteria and best practices for oral and maxillofacial pathology. The DABOMP certification emphasizes this integrated approach, requiring diplomates to demonstrate proficiency in recognizing and interpreting the oral and maxillofacial signs of systemic conditions. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based evaluation that directly addresses the diagnostic question posed by the clinical presentation. This involves correlating the observed maxillofacial changes with known systemic disease patterns, considering differential diagnoses, and recommending appropriate investigations. This aligns with the ethical obligation to provide competent and comprehensive patient care, grounded in scientific knowledge and diagnostic accuracy, as expected of a DABOMP diplomate. The regulatory framework for DABOMP implicitly mandates this level of diagnostic rigor. An incorrect approach that focuses solely on the histopathological features without considering the broader clinical context fails to meet the diagnostic requirements for systemic disease impact. This is a regulatory failure, as it neglects the comprehensive assessment expected of a specialist in oral and maxillofacial pathology, potentially leading to incomplete or inaccurate diagnoses. Another incorrect approach that relies on anecdotal experience or unvalidated diagnostic methods is ethically unacceptable, and a failure to adhere to evidence-based practice, which is a cornerstone of professional competence and patient safety. Such an approach could lead to misdiagnosis, delayed treatment, and harm to the patient, violating the core principles of medical ethics and professional responsibility. The professional decision-making process for similar situations should involve a structured approach. 1. Thoroughly review all available clinical information, including patient history, symptoms, and physical examination findings. 2. Formulate a comprehensive differential diagnosis, considering both local and systemic etiologies. 3. Identify key diagnostic features that support or refute each differential. 4. Determine the most appropriate diagnostic investigations, which may include imaging, laboratory tests, or biopsies, based on the differential diagnosis and established guidelines. 5. Integrate all findings to arrive at a definitive diagnosis and recommend a management plan in collaboration with other healthcare professionals as needed. Question 13. When evaluating a 55-year-old male presenting with a rapidly enlarging, firm and non-tender mass in the left parotid gland, which has been present for approximately 3 months, an initial panoramic radiography shows no obvious bony involvement but a poorly defined soft tissue mass, what is the most appropriate next step in the diagnostic workup? Option A. Order a contrast-enhanced computed tomography (CT) scan of the head and neck to better delineate the mass and its relationship to surrounding structures. Option B. Proceed directly to a complete excisional biopsy of the entire parotid gland to ensure complete removal and diagnosis. Option C. Perform a fine needle aspiration (FNA) biopsy of the mass to obtain cytological material for evaluation. Option D. Prescribe a course of broad-spectrum antibiotics to rule out an infectious etiology like sialadenitis. The correct answer is C. Perform a fine needle aspiration (FNA) biopsy of the mass to obtain cytological material for evaluation. Explanation. This scenario presents a common challenge in oral and maxillofacial pathology, differentiating between benign and malignant salivary gland lesions based on initial clinical and radiographic findings, and then determining the appropriate diagnostic pathway. The professional challenge lies in the potential for misdiagnosis, which can lead to delayed or inappropriate treatment, impacting patient outcomes and potentially violating standards of care. Careful judgment is required to balance the need for definitive diagnosis with avoiding unnecessary invasive procedures. The correct approach represents best professional practice by prioritizing a systematic and evidence-based diagnostic strategy. This involves obtaining a comprehensive patient history, performing a thorough clinical examination, and utilizing appropriate imaging modalities to gather as much information as possible before proceeding to more invasive diagnostic steps. When suspicion for malignancy is high or definitive diagnosis cannot be achieved through less invasive means, a biopsy is indicated. The choice of biopsy technique, fine needle aspiration, core needle biopsy, or excisional biopsy, should be guided by the suspected lesion type, location, and size, aiming for diagnostic accuracy while minimizing morbidity. This aligns with the principles of responsible medical practice and the ethical obligation to provide competent care, ensuring that diagnostic decisions are well-founded and patient-centered. An incorrect approach would be to immediately proceed to excisional biopsy for any salivary gland swelling, without adequate preliminary investigation. This fails to consider less invasive diagnostic options that might yield sufficient information, potentially leading to unnecessary surgical morbidity and increased healthcare costs. Ethically, this approach could be seen as a failure to adhere to the principle of do no harm by subjecting the patient to a more invasive procedure than might be warranted. Another incorrect approach would be to rely solely on radiographic findings without considering clinical presentation or the possibility of sampling error in a biopsy. Radiographic features can be suggestive, but are rarely pathognomonic for malignancy, and a biopsy is crucial for definitive histopathological diagnosis. Failure to obtain a biopsy when indicated would be a significant regulatory and ethical failure, as it bypasses the gold standard for diagnosing salivary gland tumors and could lead to missed or delayed cancer diagnosis and treatment. The professional decision-making process for similar situations should involve a stepwise approach. 1. Gather comprehensive clinical data, history, physical exam. 2. Utilize appropriate imaging to assess lesion characteristics. 3. Consider less invasive diagnostic methods, e.g., FNA if indicated and feasible. 4. If definitive diagnosis is not achieved or malignancy is strongly suspected, proceed to biopsy, selecting the most appropriate technique. 5. Integrate all findings to formulate a treatment plan. This systematic process ensures that diagnostic decisions are informed, patient safety is prioritized, and resources are utilized efficiently. Question 14. The audit findings indicate that a submitted case involving a complex cleft palate anomaly lacked detailed consideration of potential underlying embryological disruptions beyond the primary defect. The pathologist's report primarily described the gross and microscopic features of the cleft, but did not extensively explore associated developmental variations or their potential syndromic implications. Which of the following approaches best reflects the expected standard of practice for a diplomate of the American Board of Oral and Maxillofacial Pathology, DABOMP, in evaluating such a case? Option A. A summary of the findings that relies heavily on external literature references to explain the anomaly, without a thorough integration of the specific case's microscopic and clinical data. Option B. A concise description of the cleft lip and palate morphology, focusing on the immediate surgical considerations without extensive discussion of embryological origins or potential syndromic associations. Option C. A report that primarily lists differential diagnoses based on gross appearance, with minimal emphasis on microscopic findings or the embryological basis of the anomaly. Option D. A comprehensive evaluation that includes detailed morphological assessment, consideration of potential embryological etiologies and associated anomalies, and clear communication of diagnostic significance to the clinical team. The correct answer is D. A comprehensive evaluation that includes detailed morphological assessment, consideration of potential embryological etiologies and associated anomalies, and clear communication of diagnostic significance to the clinical team. Explanation. This scenario is professionally challenging because it requires the pathologist to integrate diagnostic findings with an understanding of the embryological basis of developmental anomalies and their potential impact on patient management and prognosis. The challenge lies in accurately identifying subtle or complex variations and communicating their significance effectively to the clinical team, adhering to the standards of practice expected by the American Board of Oral and Maxillofacial Pathology, DABOMP. The correct approach represents best professional practice by emphasizing a comprehensive diagnostic evaluation that includes detailed morphological assessment, consideration of potential genetic or environmental etiologies, and clear communication of findings. This aligns with the DABOMP commitment to rigorous diagnostic standards and the pathologist's role in providing essential information for patient care. Specifically, a thorough microscopic examination, correlation with clinical and radiographic data, and consultation with specialists when necessary are fundamental to accurate diagnosis and appropriate patient management, reflecting the high standards of expertise expected of a diplomate. An incorrect approach that focuses solely on a superficial description of the anomaly without considering its underlying pathogenesis or clinical implications fails to meet the diagnostic depth required by the DABOMP. This oversight can lead to incomplete patient assessment and suboptimal treatment planning. Another incorrect approach that neglects to document potential associated anomalies or syndromic features represents a failure to provide a complete pathological assessment, potentially missing critical diagnostic clues that could influence patient care and genetic counseling. Furthermore, an approach that does not facilitate clear communication with the clinical team, perhaps by using overly technical jargon without explanation or failing to highlight the significance of the findings, undermines the collaborative nature of patient management and deviates from professional ethical obligations to ensure understanding. The professional decision-making process for similar situations should involve a systematic approach. First, meticulously examine all available microscopic and macroscopic evidence. Second, integrate this evidence with clinical history, imaging, and any other relevant patient data. Third, consider the differential diagnosis, paying close attention to the embryological origins and potential sequelae of developmental anomalies. Fourth, consult literature or experts when encountering unusual or complex cases. Finally, communicate findings clearly and concisely to the referring clinician, highlighting diagnostic certainty, potential implications, and recommendations for further investigation or management, all within the scope of oral and maxillofacial pathology practice, as defined by DABOMP guidelines. Question 15. Cost-benefit analysis shows that while adjunctive technologies for oral cancer screening can increase detection rates in certain populations, their widespread implementation in routine general practice may not be cost-effective for all patients. Considering the evidence-based approach to oral cancer screening and early detection, which of the following strategies best aligns with current professional recommendations and ethical considerations for a general dental practice? Option A. Prioritize a comprehensive visual and tactile examination of the oral cavity and oropharynx at every recall appointment, supplemented by adjunctive technologies only when indicated by specific risk factors or clinical suspicion. Option B. Rely exclusively on patient self-reporting of symptoms and concerns as the primary method for identifying potential oral cancer without performing routine clinical examinations. Option C. Focus solely on screening high-risk populations, such as heavy smokers and drinkers, and defer routine screening for all other patient demographics. Option D. Implement universal screening with a specific adjunctive technology for all adult patients at every dental visit, regardless of risk factors, to maximize early detection opportunities. The correct answer is A. Prioritize a comprehensive visual and tactile examination of the oral cavity and oropharynx at every recall appointment, supplemented by adjunctive technologies only when indicated by specific risk factors or clinical suspicion. Explanation. This scenario presents a common implementation challenge in oral cancer screening, balancing the desire for comprehensive patient care with the practical realities of resource allocation and evidence-based practice. The professional challenge lies in determining the most effective and ethically sound approach to integrating oral cancer screening into routine practice, considering the varying levels of evidence for different modalities and the potential for overdiagnosis or unnecessary interventions. Careful judgment is required to navigate these complexities and ensure patient benefit while adhering to professional standards and guidelines. The correct approach represents best professional practice because it prioritizes evidence-based modalities that have demonstrated efficacy in improving patient outcomes for oral cancer detection. Adherence to guidelines from recognized professional bodies, such as those that might be referenced by the American Board of Oral and Maxillofacial Pathology, DABOMP, in its educational and examination materials, ensures that screening practices are grounded in scientific consensus and patient safety. This approach minimizes the risk of false positives and unnecessary anxiety or procedures for patients, while maximizing the likelihood of detecting oral cancer at an early, more treatable stage. It aligns with the ethical principle of beneficence by acting in the best interest of the patient through the most effective means available. An incorrect approach that relies solely on adjunctive technologies without robust evidence of improved outcomes, or that mandates universal screening with unproven methods, fails to meet professional standards. Such approaches may lead to increased healthcare costs without a commensurate improvement in patient survival or quality of life, potentially violating the principle of non-maleficence by exposing patients to unnecessary procedures or anxiety. Furthermore, failing to consult or adhere to established professional guidelines could be considered a breach of professional responsibility and ethical conduct, as it deviates from the collective wisdom and evidence base established by the specialty. Another incorrect approach might involve neglecting routine visual and tactile examination, which remains a cornerstone of oral cancer screening and is supported by extensive clinical experience and evidence. The professional decision-making process for similar situations should involve a thorough review of current scientific literature and established clinical guidelines relevant to oral cancer screening. Professionals should critically evaluate the evidence supporting any proposed screening modality, considering its sensitivity, specificity, positive predictive value, and impact on patient outcomes. They should also consider the cost-effectiveness and feasibility of implementation within their practice setting. Ethical considerations, including patient autonomy, informed consent, and the principles of beneficence and non-maleficence, must guide all decisions. Regular professional development and engagement with specialty organizations are crucial for staying abreast of evolving best practices. Question 16. Compliance review shows that a pathologist, newly certified by the DABOMP, examined a biopsy of an exophytic lesion from the buccal mucosa. Microscopic examination revealed a proliferation of fibroblasts and collagen, consistent with a fibrous lesion. However, the pathologist noted some increased cellularity and occasional multinucleated giant cells within the lesion, features that are not typical for a simple fibroma, but could be seen in other reactive or neoplastic processes. The pathologist is considering how to proceed with the final diagnosis and report. Option A. Consult with a senior oral and maxillofacial pathologist or a colleague with extensive experience in soft tissue pathology to discuss the atypical features and confirm the diagnosis. Option B. Report the lesion as fibrous lesion. Cannot rule out malignancy due to the presence of increased cellularity and giant cells. Option C. Immediately classify the lesion as a peripheral giant cell granuloma based on the presence of multinucleated giant cells, without further investigation. Option D. Issue a final report diagnosing a benign fibroma, as the overall architecture is predominantly fibrous and the atypical features are minor. The correct answer is D. Issue a final report diagnosing a benign fibroma, as the overall architecture is predominantly fibrous and the atypical features are minor. Explanation. This scenario presents a professional challenge due to the potential for misdiagnosis and the subsequent impact on patient care and trust. The pathologist's responsibility extends beyond simply identifying a lesion. It includes ensuring the diagnosis is accurate, well-supported, and communicated effectively to the treating clinician. The core of the challenge lies in balancing the urgency of a potentially concerning finding with the need for thoroughness and adherence to established diagnostic protocols. The correct approach represents best professional practice because it prioritizes patient safety and diagnostic accuracy. By seeking consultation with a senior colleague or a specialist in oral and maxillofacial pathology, the pathologist ensures that a second, experienced opinion is obtained for a lesion that exhibits atypical features. This aligns with the ethical obligation to provide competent care and the DABOMP implicit expectation of continuous learning and peer review. It also demonstrates a commitment to upholding the highest standards of diagnostic integrity, which is fundamental to the profession and the board certification. This process minimizes the risk of error and ensures the most appropriate management plan for the patient. An incorrect approach that involves immediately classifying the lesion as a benign fibroma without further investigation or consultation is professionally unacceptable. This failure constitutes a breach of diagnostic diligence. It bypasses the critical step of considering differential diagnoses for lesions with atypical features, potentially leading to an incorrect diagnosis and inappropriate patient management. This could result in delayed or missed treatment for a more serious condition, violating the ethical duty to act in the patient's best interest. Furthermore, it disregards the principle of seeking expert opinion when faced with diagnostic uncertainty, a cornerstone of responsible pathology practice. Another incorrect approach, which is to dismiss the atypical features as insignificant and proceed with a routine report, is also professionally unacceptable. This demonstrates a lack of critical appraisal of the microscopic findings and a failure to recognize potential diagnostic red flags. It neglects the responsibility to thoroughly evaluate all aspects of a specimen, especially when subtle deviations from the norm are observed. This can lead to a misdiagnosis with serious consequences for the patient, undermining the credibility of the pathologist and the diagnostic process. The professional reasoning process in such situations should involve a systematic evaluation of the microscopic findings. When atypical features are noted, the pathologist should 1. Thoroughly review the literature for differential diagnoses associated with those features. 2. Consider the clinical information provided. 3. Consult with experienced colleagues or specialists within the field of oral and maxillofacial pathology. And 4. Document the diagnostic process, including consultations and the rationale for the final diagnosis. This methodical approach ensures that all diagnostic possibilities are considered and that the final diagnosis is robust and defensible, ultimately serving the best interests of the patient. Question 17. Strategic planning requires a pathologist to accurately assess prognostic factors for oral and maxillofacial lesions, considering a case with potential for recurrence and metastases. Which approach best informs the clinician regarding the likely behavior of the lesion and guides subsequent patient management? Option A. Making a prognostic determination based solely on the presence of a single, commonly observed histological feature that has been anecdotally associated with poorer outcomes. Option B. Focusing exclusively on the patient's age and general health status, assuming these are the primary determinants of lesion prognosis. Option C. Relying on a combination of established histopathological features, validated immunohistochemical markers, and correlation with clinical presentation to predict lesion behavior. Option D. Prioritizing the speed of reporting by providing a general prognosis without detailed microscopic evaluation or consideration of ancillary studies. Correct answer is C. Relying on a combination of established histopathological features, validated immunohistochemical markers, and correlation with clinical presentation to predict lesion behavior. Explanation. This scenario is professionally challenging because the accurate assessment of prognostic factors in oral and maxillofacial pathology directly impacts patient management, treatment planning, and ultimately patient outcomes. Misinterpreting or inadequately evaluating these factors can lead to suboptimal care, unnecessary morbidity, or missed opportunities for more aggressive intervention when indicated. The DABOMP certification emphasizes a high level of expertise in this area, requiring a thorough understanding of the nuances of histopathology, molecular markers, and clinical correlation to predict disease behavior. The correct approach represents best professional practice because it involves a comprehensive, evidence-based evaluation of all relevant prognostic indicators. This aligns with the ethical obligation to provide the highest standard of care and the regulatory expectation that pathologists utilize all available tools and knowledge to inform clinical decisions. Specifically, in the context of U.S. regulations governing medical practice and board certification, this approach upholds the principles of patient safety and informed consent, as accurate prognostic information is crucial for patients to make informed decisions about their treatment. It also reflects the commitment to continuous learning and the application of the latest scientific advancements in pathology, which is a cornerstone of professional responsibility. An incorrect approach that relies solely on a single, non-validated histological feature fails to meet professional standards. This is because it ignores the multifactorial nature of prognosis and the established scientific literature that supports the use of a combination of factors. Ethically, this approach could lead to misinformed treatment decisions, potentially harming the patient by either undertreating a more aggressive lesion or overtreating a less aggressive one. From a regulatory perspective, it demonstrates a lack of due diligence and adherence to established diagnostic and prognostic criteria, which could be grounds for professional review. Another incorrect approach that prioritizes expediency over thoroughness, such as making a prognostic determination without adequate microscopic review or correlation with clinical information, is also professionally unacceptable. This bypasses critical steps in the diagnostic process and can lead to significant errors. It violates the ethical duty to provide careful and meticulous professional services and contravenes regulatory expectations for diagnostic accuracy and completeness. The professional decision-making process for similar situations should involve a systematic approach. First, a thorough review of the histopathology, identifying all relevant morphological features. Second, consideration of ancillary studies, e.g., immunohistochemistry, molecular testing, if indicated and available, as these often provide crucial prognostic information. Third, correlation with the available clinical and radiographic data to ensure a holistic understanding of the case. Finally, integrating all this information with current scientific literature and established prognostic models to formulate an accurate and clinically relevant assessment of prognostic factors and likely outcomes. This systematic, evidence-based, and clinically correlated approach ensures the highest quality of patient care and adherence to professional and regulatory standards. Question 18. The efficiency study reveals a statistically significant increase in the incidence of oral squamous cell carcinoma (OSC) among individuals aged 50-70 residing in a specific urban county over the past decade. Considering the established epidemiological data and known risk factors for OSC, which of the following represents the most appropriate next step for an oral and maxillofacial pathologist to contribute to understanding and addressing this trend? Option A. Initiate a detailed review of the diagnostic criteria and histological classifications used in the pathology reports for OSC cases within that county during the study period to ensure consistency and accuracy. Option B. Advise local dental practitioners to increase the frequency of routine oral cancer screenings for all age groups, irrespective of specific risk factor profiles. Option C. Recommend a public awareness campaign focused on general oral hygiene practices without specific correlation to the observed demographic or geographic trends. Option D. Conduct a retrospective analysis of patient records from the affected county, correlating the OSC diagnosis with detailed lifestyle questionnaires, occupational histories, and environmental exposure data for the identified demographic. Correct answer is A. Initiate a detailed review of the diagnostic criteria and histological classifications used in the pathology reports for OSC cases within that county during the study period to ensure consistency and accuracy. Explanation. The efficiency study reveals a statistically significant increase in the incidence of oral squamous cell carcinoma (OSC) among a specific demographic group within a defined geographic region over the past decade. This scenario is professionally challenging because it requires the oral and maxillofacial pathologist to move beyond diagnostic interpretation and engage with public health implications. The pathologist must consider the broader epidemiological context, identify potential contributing factors, and contribute to strategies for prevention and early detection, all while adhering to the ethical and professional standards set forth by the American Board of Oral and Maxillofacial Pathology, DABOMP. The DABOMP purview extends to understanding the natural history, epidemiology, and clinical behavior of oral and maxillofacial diseases, which directly informs public health initiatives and professional practice guidelines. The correct approach involves a comprehensive review of the epidemiological data, correlating the observed increase with known and potential risk factors for OSC. This includes evaluating lifestyle factors, environmental exposures, genetic predispositions, and access to healthcare within the affected demographic and region. The pathologist's role is to synthesize this information, identify plausible etiological links, and communicate these findings to relevant stakeholders, such as public health agencies, dental and medical professionals, and researchers. This aligns with the DABOMP commitment to advancing the science and practice of oral and maxillofacial pathology through research, education, and the dissemination of knowledge that can improve patient outcomes and public health. An incorrect approach would be to dismiss the findings as a statistical anomaly without further investigation. This fails to acknowledge the pathologist's responsibility to contribute to the understanding and management of oral diseases at population level, a core tenet of the DABOMP educational and certification objectives. Another incorrect approach would be to focus solely on the diagnostic aspects of individual cases without considering the epidemiological trends. This limits the pathologist's impact and neglects the broader public health implications of disease patterns. Furthermore, speculating on unproven or unsubstantiated risk factors without rigorous scientific backing would be professionally irresponsible and ethically unsound, potentially leading to misinformed public health interventions. The professional decision-making process for similar situations should begin with a thorough understanding of the epidemiological data presented. This involves critically evaluating the study's methodology, statistical significance, and the identified demographic and geographic parameters. The next step is to consult established literature and databases on OSC epidemiology and risk factors, specifically looking for correlations with the observed trends. Collaboration with epidemiologists, public health officials, and other relevant medical specialists is crucial for a comprehensive analysis. Finally, the pathologist must communicate their findings and recommendations clearly and responsibly, emphasizing evidence-based conclusions and potential avenues for further research or intervention, in line with the highest standards of professional conduct and scientific integrity expected by the DABOMP. Question 19. Cost-benefit analysis shows that performing an additional immunohistochemical stain on a previously diagnosed benign lesion would have a low probability of altering the initial diagnosis or treatment plan, but would incur additional laboratory costs and a slight increase in turnaround time. The referring clinician has expressed satisfaction with the initial diagnosis and is not requesting further clarification. Option A. Suggest a repeat biopsy to obtain fresh tissue for further testing, as the current tissue may be suboptimal for additional stains. Option B. Inform the referring clinician that the additional stain is unlikely to be beneficial and ask if they still wish to proceed, deferring the decision entirely to them. Option C. Recommend against the additional immunohistochemical stain, documenting the rationale based on the low probability of diagnostic alteration and the absence of a clear clinical indication. Option D. Proceed with the additional immunohistochemical stain to provide the most comprehensive diagnostic information possible, regardless of the low probability of altering the outcome. The correct answer is C. Recommend against the additional immunohistochemical stain, documenting the rationale based on the low probability of diagnostic alteration and the absence of a clear clinical indication. Explanation. This scenario presents a professional challenge due to the inherent conflict between the desire to provide comprehensive diagnostic information and the ethical obligation to avoid unnecessary or potentially misleading procedures. The pathologist must balance the potential diagnostic yield of an additional, more invasive test against the patient's well-being, the financial implications for the patient and healthcare system, and the principle of avoiding harm. The DABOMP framework emphasizes evidence-based practice, patient advocacy, and professional integrity, all of which are tested in this situation. The correct approach represents best professional practice because it prioritizes patient welfare and adheres to the principle of judicious use of diagnostic resources. It involves a thorough evaluation of existing data, consultation with the referring clinician to understand the clinical context and the limitations of current findings, and a reasoned decision based on the likelihood of the additional test providing clinically significant, actionable information that outweighs its risks and costs. This aligns with the ethical guidelines for medical professionals, which mandate that diagnostic interventions should be both necessary and beneficial. An incorrect approach that proceeds with the additional, invasive test without a clear clinical indication or sufficient justification fails to uphold the principle of non-maleficence, do no harm, and beneficence act in the patient's best interest. It may lead to unnecessary patient discomfort, potential complications, and increased healthcare costs without a commensurate diagnostic benefit. This also violates the principle of professional responsibility to use resources wisely. Another incorrect approach, which is to dismiss the possibility of further investigation solely based on the initial findings without adequate consultation or consideration of the clinical nuances, could lead to a misdiagnosis or delayed treatment. This neglects the pathologist's role in providing the most accurate and complete diagnostic information possible to guide patient care. The professional decision-making process in such situations should involve a systematic evaluation. First, thoroughly review all available data. Second, engage in open communication with the referring clinician to understand the clinical question and the implications of different diagnostic pathways. Third, consider the risks, benefits, and costs of any proposed additional investigations. And finally, make a recommendation that is ethically sound, clinically justified, and in the best interest of the patient. Question 20. The audit findings indicate a discrepancy in the diagnostic workup of a patient presenting with a radiolucent lesion of the mandible. The initial radiographic interpretation suggested a benign process, but subsequent histopathologic examination revealed features concerning for malignancy. Which of the following diagnostic approaches best reflects the rigorous standards expected for a diplomate of the American Board of Oral and Maxillofacial Pathology in resolving such a diagnostic challenge? Option A. Conduct a comprehensive review of all available data, including a detailed re-examination of the radiographic images in conjunction with the histopathologic findings, and consult with relevant specialists if necessary to achieve a definitive diagnosis. Option B. Reevaluate the radiographic images with a focus on identifying subtle signs that might support a benign interpretation, potentially downplaying the histopathologic findings if they strongly contradict the initial radiographic impression. Option C. Prioritize the histopathologic findings as definitive and proceed with treatment recommendations based solely on the biopsy report, assuming the radiographic interpretation was flawed. Option D. Request a repeat biopsy without further analysis of the existing data, assuming the initial biopsy was not representative of the lesion. The correct answer is C. Prioritize the histopathologic findings as definitive and proceed with treatment recommendations based solely on the biopsy report, assuming the radiographic interpretation was flawed. Explanation: the audit findings indicate a potential deficiency in the diagnostic workflow for jawbone pathology, specifically concerning the interpretation of radiographic and histopathologic findings. This scenario is professionally challenging because accurate diagnosis of jawbone lesions, such as osteomyelitis and osteosarcoma, is critical for patient prognosis and treatment planning. Misinterpretation can lead to delayed or inappropriate interventions, with potentially severe consequences. The DABOMP certification emphasizes a rigorous understanding of oral and maxillofacial pathology, requiring practitioners to integrate clinical, radiographic, and histopathologic data effectively. The correct approach involves a systematic and comprehensive review of all available diagnostic information, including detailed clinical history, thorough radiographic interpretation, e.g., panoramic, CBCT, and meticulous histopathologic examination of biopsy specimens. This integrated approach ensures that all diagnostic modalities are considered, leading to a more accurate and definitive diagnosis. This aligns with the DABOMP commitment to upholding the highest standards of diagnostic competence and patient care, as expected of a diplomate. An incorrect approach would be to rely solely on radiographic findings without adequate histopathologic correlation. Radiographic features of benign and malignant jawbone lesions can overlap, making a definitive diagnosis based on imaging alone unreliable. This failure to seek definitive histopathologic confirmation is a significant diagnostic lapse and deviates from best practices expected of a DABOMP diplomate. Another incorrect approach would be to overemphasize a single histopathologic feature without considering the broader clinico-radiographic context. Certain reactive bone patterns can mimic neoplastic processes, necessitating a holistic diagnostic evaluation. Relying on isolated findings without integrating them into the overall clinical picture can lead to misdiagnosis and inappropriate management. Professional decision-making in such situations requires a systematic process. 1. Gather all relevant data, clinical presentation, patient history, and all imaging studies. 2. Critically evaluate each data source independently. 3. Synthesize findings from all sources, identifying areas of concordance and discordance. 4. Formulate a differential diagnosis based on the integrated data. 5. If definitive diagnosis remains elusive, recommend further diagnostic steps such as advanced imaging or biopsy to obtain definitive histopathologic confirmation. 6. Communicate findings and recommendations clearly to the referring clinician.